All right, good evening. Welcome to the Wayland Library. Thank you for finding your way under here. Tonight we are excited to have Wayland resident Gary Hirsch here to talk about the persistent poppy. Gary has been consulting with organizations on management strategy and organizational change for the past 55 years, working with clients in diverse areas such as healthcare, human services, education, microfinance, and news media. He specializes in applying system dynamics and systems thinking and creating simulation-based learning environments that help clients understand the complex problems they're dealing with. He is a graduate of MIT's Sloan School of Management and the author of 3 books and numerous articles, chapters, and presentations. He was also a founder and leader of the Metro West Free Medical Program, which provides care to the uninsured, low-income population in our area. Thank you so much to Gary for being here. 2 housekeeping notes. We are recording, so you may see this on Waycam, or it will be on YouTube, so you'll be able to rewatch and share. In addition, Gary's planning to speak for about 40 minutes, and we'll hold our questions till the end. If you're on Zoom, put your question in the chat at any point, and I will raise my hand and read it aloud. Thank you.
Thanks, Courtney, for that kind introduction, and to the Wayland Public Library and its great presenters program, and to all of you for coming or watching on Zoom. A little about myself, just to start with. I grew up in Brooklyn, New York, and got, as Courtney said, bachelor's and master's degrees from MIT, the Sloan School of Management. My wife Linda and I have been Wayland residents for 51 years and raised 2 sons here. I've been a consultant in healthcare and related social problems for the past 55 years. The title of my talk comes from a book 2 colleagues and I published in 1975. In it, we shared the insights derived from studying the heroin problem in New York City. We concluded that this problem would persist as long as opioids are treated as a criminal rather than a medical problem. Unfortunately, this has proven true, including in ways we couldn't have anticipated. I'll expand on that in the next few minutes. This quote This quote by the great American political philosopher Groucho Marx describes beautifully the causes and consequences of poorly conceived public policy. So Groucho said, politics is the art of looking for trouble, finding it everywhere, diagnosing it incorrectly, and applying the wrong remedies. Very fitting quote. Our 50-plus year journey will take us through the heroin epidemic in the early 1970s in New York City, how the poorly thought out solution to that epidemic created a new problem, mass incarceration, the consequences of mass incarceration for poor minority communities, how prescription opioids became the new drug of choice and spread the problem across races and classes, how poorly conceived policies for controlling prescription opioids led to new demand for heroin and the rise in the drug cartels and later fentanyl and many overdose deaths, and how an enduring punitive mindset delayed an effective response to addiction while many died. So my talk tonight will have 4 intertwined threads. It's in many ways a personal memoir work I've done on various aspects of the problem, how the opioid problem in the U.S. has evolved over the past 50 years, how poorly thought out public policy can create new or worse problems, and how the techniques of systems thinking and system dynamics can help us better understand complex social problems. System dynamics is a set of techniques developed at MIT by J. Forrester. Forrester was an electrical engineering professor who applied electrical control system theory to industrial problems, understanding how they happened, and to industrial problems initially, and later to urban and global problems. System dynamics enables those responsible for complex systems like a city to understand how those systems could generate their own problems and how poorly designed solutions could make them worse. It's been widely applied to problems in business, public policy, environment, many other areas. I was fortunate enough to study with Jay Forrester and his associates Ed Roberts and Jack Pugh, and went on to apply system dynamics to a wide variety of problems in healthcare and social policy, areas like youth homelessness in the U.S. and in other countries. My part of the opioid story begins when I was still an undergraduate at MIT's Sloan School of Management in 1969. I was accepted at several graduate programs. One of my professors, Ed Roberts, took me to lunch and said, if you stay here at Sloan, I'll give you a part-time job with my consulting firm, Pugh Roberts Associates. So part-time job plus graduate study sounded good, and I decided to stay. I later learned that also brought with it a draft deferment because the job involved working in healthcare. This was a very valuable employee benefit for a young man in that era. Our first client was the Community Mental Health Center located in the East Bronx. The Soundview Throgsneck Center was part of a wave of these centers designed to take clients out of large state hospitals and care for them in the community. It was operated by the Albert Einstein College of Medicine. It served a mixed income community of about 180,000, 20% of whom were lower income minorities, a percentage that was steadily increasing. The work was funded by the National Institute of Mental Health that wanted to see how systems techniques could help the centers provide better care. After doing some work to help the center keep patients out of hospitals, we asked, what is your community's biggest mental health problem? Without hesitation, they answered, heroin addiction. It's just no doubt at all. That was what they were really most concerned about at that point. At that point, in the early 1970s, New York City was in rough shape, as reflected in this image of kids using an abandoned car as a playground. The city faced a financial crisis that led to cutbacks in a wide range of services. Crime was also a growing problem. Heroin use had been at a low level for many years, but exploded in the early 1970s. Conditions in New York City provided the fuel for a heroin epidemic. Veterans returning from Vietnam, where they had become addicted to heroin, provided the match. Heroin just caught fire and began spreading around the city. We began our work by talking to a broad cross-section of people with some connection to the heroin epidemic. Mental health professionals, local government officials, community members, police officials, ex-addicts running treatment programs. Each had their own unique perspective on the problem. People advocating for different approaches, unfortunately, were talking past each other, which made it difficult to agree on remedies. How could we create a common picture so that everyone could relate to when their mental models, their mental images of the problem were so different? So we had a set of tools from system dynamics, a visual language that enabled us to describe the causes of this complex problem. This visual map of causes could then be translated into a computer program that projected different scenarios as simulations over time. These simulations enabled us to explore potential solutions and also to avoid unintended consequences, the wrong remedies that Groucho warned us about. We started by describing the factors that drove the rapid escalation in heroin use that was alarming the community. This is what we call a causal diagram, outlining the causal relationships that drive or control a problem. Each arrow in the diagram describes a causal relationship between two variables. For example, in this diagram, the availability of heroin contributes to determining the rate at which new people become addicts. Notice that these causal arrows form two closed loops. These are called feedback loops. That term may be familiar to many of you, for example, from listening to discussions about climate change. Feedback loops are ubiquitous. They're everywhere, and certainly we're relevant here. In system dynamics, we focus on them because they drive the change or behavior of concern to us, such as, in this case, the number of addicts. There are two types of feedback loops. The R represents a reinforcing loop, one that drives or accelerates change. These are often called vicious cycles when they create runaway problems. They can also work in the other direction, and they're called virtuous cycles when they promote something like growth of a good thing. The growth in addiction community experience appeared to have two sources: addicts attracting others to become addicts through peer pressure. Addicts, as the number of addicts grew, peer pressure drew in more new addicts, adding to the addicts on the street. Similarly, as the number of addicts grew, the demand for heroin grew. Pushers were more than happy to provide the additional heroin. The availability of the new heroin made it possible for new people to become addicts, adding to the addicts on the street. So all of these essentially reinforced the growth in the addict population. So what would happen if these feedback loops operated unimpeded? Well, to find out, we developed a computer model based on these causal relationships to project how the heroin problem in this area of the Bronx could evolve over time. The backbone of the model was a set of flows that traced how people become addicts and the various things that happen to them once addicted, entering rehab programs, being arrested and jailed, completing rehab and re-entering the community. Simulations with the model projected that if nothing changed, the number of addicts on the street would grow to 8,000. This is in a community of about 180,000 people, so that's quite a few addicts over a 20-year period, just continuous growth, and that crime would increase in parallel. Those of you who have been using computers for a long time may notice that in the old days there weren't fancy plotters. You just graphs were made by printing out strings of letters letters over time. But of course there were other things going on that we included in our model. The community saw the heroin problem most vividly in terms of the crime that resulted from addicts needing money to support their habits and the need for more police to combat crime. This slide shows where crime and the police effort to combat it fit in. The causal arrows form another kind of loop, a balancing loop shown by a B. The balancing loops actually work against change. Reinforcing loops push change in the same direction. Balancing loops work against it. So, for example, as crime increased and there was more police effort, there would be more arrests, fewer addicts on the street, more addicts in jail and in prison, and less crime. So that sort of balancing effect also worked through the availability, police effort reducing the availability of heroin, reducing the number of new addicts, reducing addicts on the street, and less crime. So both of these loops really worked against the growth in the number of addicts and crime. But unfortunately, as we thought about it more, there were a couple of additional feedback loops that complicated the situation and made it considerably worse. One was that as police effort reduced the availability of heroin, the price of heroin went up. More crime had to be committed to support the habits of the addicts in the community. There was more crime, more police effort, and so this was actually driving crime in an upward direction. Even though police were trying to do the right thing and reduce the availability of heroin, they were indirectly and unintendedly helping to drive up crime. By the same token, crime also affected the population, and people who could afford to moved out and were replaced as the attractiveness of the community went down, replaced by people at a lower socioeconomic level. And poorer communities, unfortunately, had higher prevalence of addiction, and so new addicts, this contributed to the rate of new addicts, people becoming new addicts, more addicts on the street, more crime, and creating something of a downward spiral, really, for the community, which the Soundview-Throgsneck community was, I think, just beginning to experience. When these elements are added to the computer model, we get a different, but still disappointing picture of how the heroin problem might evolve in the community. The number of street addicts sort of was up here in the previous computer plot, but now is down here, and but the number of addicts on the street and in jail in total remained about the same, but unfortunately the ones in jail were not getting any kind of treatment. They were likely to just go back to addiction when they left jail. And crime was absolutely would have gone through the roof, because not only was the price of heroin driven up, requiring more crime to support the habits of the addicts in the community, but as the community's socioeconomic level dropped, this line of L's, as that level dropped, there was a tendency for more crime as well. So a very unfortunate picture. So clearly we needed to add some things to the model. So we added a couple more balancing loops. Naturally, rehabilitation, as the number of addicts on the street increased, we assumed that if capacity existed in treatment programs, more addicts would be in rehabilitation, fewer addicts on the street. Also that preventive education programs could help to reduce the number of new addicts. So we added those to the model, and had the model produce some really impressive results. There's a turnaround. The numbers of addicts and crime peaked after a couple of years and then declined sharply. So that seemed impressive, but wait, that wasn't really happening out in the real-world Bronx. Things were getting worse and really showed no sign of slowing down. There was something we were missing in the model. We scratched our heads quite a bit. And then we saw an article that gave us a hint. There was an article about a vacant building that was being proposed for a rehab facility, but the neighbors who lived right around it turned out in force against arguing against this, arguing that it would bring addicts and crime into their neighborhood, even though we knew that there were many addicts already living there who could really use the facility. The community argued for more police instead. It became apparent that there couldn't be an effective solution to the heroin epidemic if the community continued to see it merely as a criminal rather than a medical problem. There had to be a shift in the community's definition of the heroin problem. We added that shift in definition of the problem to the model, highlighting the need for community education to make that shift happen. The community also had to go through a learning process of seeing that law enforcement wasn't really solving the problem. It was just moving it from the street to jail. And that problem existed in their own neighborhood. It wasn't just addicts coming from another neighborhood to commit crime. The problem existed among their own friends and families. Our model simulated what could happen if that shift was achieved. With that shift in definition and being able to create rehab programs, there was able to be a turnaround. There would be able to be a turnaround in crime. The number of street addicts could go down. Addicts in prison would go down as well. And a large number of addicts, still, sort of a very high total, but the majority would be in various methadone programs and would not be committing crimes, would not be overdosing on heroin, and had a chance at achieving rehabilitation. So the key insights that we derived from the work were the need for this shift in definition of the problem from criminal to medical, and a comprehensive, balanced approach employing multiple interventions rather than the solo solutions being advocated by people advocating for one or the other, yelling past each other. So our work got the attention of some key people involved in the city's fight against heroin, including its Commissioner of Addiction Services, Graham Finney. Finney was so impressed with our work that he arranged to have us present before Mayor Lindsay's full narcotics council, made up of the heads of all the departments that had anything to do with narcotics. Police, health, mental health, education. It's this long table filled with all the really senior people in the city that had anything to do with narcotics. So this was something we're really excited about. We were all set to give a dazzling presentation, including me, the young MIT computer nerd, sitting at a terminal ready to run different scenarios that the group might ask about. Unfortunately, our presentation coincided with a cutback in state funding for addiction programs that had occurred the day before. This was obviously on everyone's minds. They listened politely for a while, but our presentation was cut short. We were invited to stay and got to watch the city's leadership struggle with the arithmetic of reallocating limited funds, and they kept getting it wrong, all that brain power in the room, and they kept struggling just to reallocate the funds, too little funding for programs that probably needed quite a bit more. Nonetheless, we continued to work with Finney and had, I feel a positive effect on the city's strategies for dealing with the heroin epidemic. Ed Roberts and I, along with our colleague Gil Levin, a psychology professor at Einstein, published The Persistent Poppy in 1975. We also continued giving presentations to other groups. However, there was a major change at the state level that totally undermined the city's balanced approach and effectively snatched defeat from the jaws of victory. Governor Nelson Rockefeller, who had been a liberal in his policies, suddenly decided to get tough on crime and instigated the passage of a draconian set of drug laws that imposed long, long prison sentences for even low-level dealing. This heavily skewed New York's drug policies in the punitive direction, and also became the opening act in the incarceration crisis that spread across the entire U.S. Put this out of the way so I don't spill it. So New York's prison and jail populations grew enormously, fourfold between 1978 and 1998 when the prison population peaked. The jail population peaked a little sooner. But just huge, huge growth before finally declining. Nationally, things were even worse, if you could believe that. Between the early 1970s and 2008, when the national prison population peaked, it was like a five-fold increase. It was just huge. You can imagine how many prisons needed to be built, and many people kept in prison, and finally leveled off and began declining after 2008. And when you include, all people who were somewhat under the control of the judicial system, or the correctional system, included probation and parole, the increases were like sevenfold between 1980 and 2010. Just enormous number of people who were somewhat under the control of the correctional system. And ironically, this was occurring while crime was actually going down. Rates of homicide, motor vehicle theft, and burglary were all declining after 1987, but the imprisonment rates, this green line, was just shooting up at the same time. This was totally irrational. There was no reason for it except this momentum that had been created around incarceration and putting people away. And it was also very costly. These two bars contrast the cost of a heroin user being in prison, a lot of losses due to lost productivity and the actual costs of incarceration themselves. So 50% greater to have a heroin user in prison as opposed to not being incarcerated. So not only were lives being lost to people being locked up, but this was costing society a lot of money. And there was a real racial aspect to the incarceration plague as well. This blue line are sort of drug arrest rates per 100,000 for blacks in the blue line as opposed to whites in the red line. Some of you may have read Michelle Alexander's book, The New Jim Crow, which details this inequity, but it fell especially hard on black and other minority communities. So sometime later, I was involved in an effort in Minnesota. The committee of the state legislature, healthcare committee, was interested in the health effects of mass incarceration. So a team I worked with at the time assembled a diverse group of stakeholders, people from the penal system, from the mental health system, prisoner advocates. We got them together and plotted out the sort of the causes, the causal factors underlying why the prison population had grown and what its effects were. This work really helped to explain why incarceration grew so rapidly and the damage it caused, especially to minority communities. And there were a set of these reinforcing loops, for example, the effects of being incarcerated in overcrowded, violent prisons with a lack of services, because they were well beyond the capacity of these prisons, had a negative effect on the mental health and substance abuse status of released offenders, and those released offenders were not able to find jobs or stable housing. They often had broken connections with their families. So the likelihood of reoffending caused them to sort of rejoin the incarcerated population and be add to the growing population. And then in addition, there were the effects on community when a lot of working age people were lost to the local economy as a result of incarceration. The health of the local economy suffered. There were fewer jobs and fewer housing opportunities for ex-offenders. The likelihood of reoffending was higher. People went back to prison and again joined the growing prison population. And then there were intergenerational effects. When people were incarcerated, they couldn't provide adequate supervision and advocacy for their kids. They also, the broken connections with families contributed to that as well. And so there was a greater likelihood that youth in the community would be seen as offenders. Often in minority communities, the standards for what constituted criminal act, it might just be sort of teenage hijinks in a suburban community, but might result in incarceration for a minority youth, and so that was adding to this growing prison population as well. And you might very well have adults and their younger adult children in prison at the same time. So that brings us to the next episode in this story, prescription opioids. These were introduced in the 1980s, and the volumes prescribed grew sharply over the next 20 years, tripling before it peaked in 2011. So in 1991, there were 76 million prescriptions. In 2011, there were 219 million, so it's roughly a tripling in the amount of hydrocodone and oxycodone prescribed. This growth was fueled by very heavy promotion by Purdue Pharma, perhaps the biggest offender, and other companies which have since been sued by the states for their contribution to this problem. The companies promoted the lie that the drugs are not addictive. A simple letter to a medical journal was taken out of context and presented as definitive research. Not at all. This was very much an American phenomenon. Comparing the U.S. and the red line, this is in oxycodone consumption per capita, the U.S. as opposed to Europe. I mean, these pharma companies were obviously concentrating their efforts in the U.S. to get that kind of growth. I'm sure the people in Europe weren't suffering all kinds of pain. It was just that the U.S. had become habituated to these prescription opioids. And starting in the 1990s, where heroin had been the drug drug of first opioid use. Up until 1990, prescription opioids then became the drug of first use. So complete, turnover in prescription drugs being what actually got people hooked on opioids. And at the same time, addiction, just because of the huge volume of these prescription opioids being distributed, there was an expansion, sort of from the poor in the ghetto, heroin epidemic of the 1970s. It became, sort of a white problem, and was just found much more broadly in the population. I skipped one. So this graph is a really interesting one. These are described as deaths of despair, and you can see that drugs up until the 1990 or so were a lesser contributor to these deaths of despair than alcohol and suicide, but starting in 1990, drugs as a source of these deaths of despair grew rapidly, and by 2015 or so exceeded suicide and alcohol as a cause of these deaths of despair. So what was the response to this growing trend? Naturally a punitive one, just given the mindset that people kept drinking to drugs. So limits were placed on prescribing by physicians and other health providers to reduce the likelihood of people becoming addicted, as well as to limit leakage into the illicit market. There were stricter enforcement against pill mills that were devastating some communities. Prescription monitoring databases were set up to catch physicians who were overprescribers, as well as catching habitual users. These were all necessary, but unfortunately, no one really thought about the couple of million people who had already become addicted and now had their drug supply cut off. Somehow they were neglected. They had to turn to street drugs, principally heroin, to satisfy their need for opioids. Let's understand the feedback loops that produced that. Again, there was this growth in prescribing, which, as more people were using prescription opioids, there was a general expectation that people didn't have to suffer pain at all. They could just take these opioids and do fine. And so that added to the volume of opioids and produced the growth in the chart that you saw. At the same time, medical providers also, their norms about when to prescribe these opioids shifted, so they were also prescribing. So sort of there's a patient demand loop and a prescriber norm loop that both were contributing to this growth, and that growth was stoked by the pharmaceutical companies, salespeople running around saying more. People shouldn't have to experience pain at all. Just give them more opioids. So as a result, more people were getting addicted to prescription opioids. Some of them because they were taking the opioids initially sort of for a legitimate reason, but then became hooked on them. And then there was also leakage into the illicit market that was also getting people addicted as well. So that number of people addicted was growing. So against these reinforcing loops, regulatory measures, were put in place. The databases, the rules about prescribing, and so on, so that the volume of opioids prescribed did go down somewhat. Leakage did go down somewhat. So fewer new people were becoming addicted, but those people already addicted, in the absence of an illicit supply due to leakage, in fact needed more heroin and other so-called street opioids. And you can see that in this graph where, starting in 2010, 2011, the use of OxyContin for by addicts to get high was going down, and the use of heroin was increasing. So this shift from prescribed opioids to street opioids, initially heroin, was definitely taking place. And so there were these additional reinforcing loops that really caused the problem to explode. People addicted to heroin and other street opioids demanded more. The cartels were very happy to begin supplying more, and more people became addicted. And there's also marketing going on by the suppliers. They would mix heroin or fentanyl in with other drugs that people might, sort of take as sort of party drugs, but then they became addicted to the opioids that were in them, and so this kept growing and growing and growing. And the cartels made the shift. Initially, they were growing poppies in Mexico and creating heroin, a certain kind of brown heroin, but they discovered it was much easier and cheaper to just manufacture fentanyl out of chemicals. So they really shifted to fentanyl. And you can see just how suddenly that exploded. In 2020, there was this huge increase in fentanyl seizures, and again, that's just fentanyl that was caught. There was probably 10 times as much getting through, especially over the border from Mexico. In the 1970s, heroin was coming in very small quantities from Afghanistan, in a couple of pound packages by plane, and in the 2020s, you had fentanyl coming, sort of by truck over the border from Mexico. So there was a huge increase. And unfortunately, sadly, there was also a huge increase in overdose deaths as fentanyl took hold. From 25,000 in 2010 up to probably about 80,000 in the 2020s. So there's just really a terrible tragedy. And fentanyl really was the major contributor. These other lines were heroin and other forms of opioids, but fentanyl was by far the larger contributor. But sadly, the punitive mentality still held back the availability of treatment. Buprenorphine emerged as an effective drug for dealing with addiction, or OUD, opioid use disorder, as it now is being called. But there were ridiculous requirements for training needed to allow doctors to prescribe these drugs, a training that I suspect was largely unnecessary. It was just a hurdle. And limits on the number of addicted people each doctor could treat. The availability of treatment grew much more slowly than it might have before it began to catch up. For example, in 2014, there were 914,000 people using heroin in the U.S. But in the same year, 2014, if you add up these lines of people in medication-assisted therapy at different ages, it's about 100,000 in these medically assisted treatment programs. So essentially 1 in 9 people who probably could have used medically assisted treatment was getting it. Now, buprenorphine was approved by the FDA for treatment of OUD in 2002, and yet in 2014, only 1 in 9 patients was getting treatment. So, and I think that also includes people on methadone as well. So there's this punitive attitude and this sort of lack of trust, especially in treatment modalities that used other opioids, really was holding back treatment, and as a result, you saw the very high overdose death rates that happened. So I'll just sort of summarize. I'm actually still working on the problem. I'm working with a group from the City University of New York's School of Public Health, and colleagues at the Albert Einstein College of Medicine. So in 50 years, I've sort of, different people, I think sadly the colleagues I worked with 50 years ago are no longer with us, but a new group of colleagues at the Einstein College of Medicine as well as City University. And we're working in New York State, looking at the different strategies for reducing the overdose death rate, both at the state level and in the counties. But the drug problem in the U.S. is far from over. The punitive response is still with us to some extent. Oregon tried legalizing the possession of opioids, but then delegalized them. I'm not sure that's a word, but delegalized them in response to a community backlash when people were using drugs out in public, and that there's a lot of pushback from the community. The use of other drugs like meth is expanding, including even while people were being treated for opioid addiction, they're using meth. Polydrug abuse is also increasing. And the current administration's cuts to Medicaid may cut down on treatment funding and options, and sadly reversing some of the progress that we've been making in reducing overdose deaths. Its emphasis on interdiction is getting the most publicity, but it's not clear how much impact that's having on supplies, since it's focused on lower volume drug routes. Blowing up boats makes good TV, but most of the drugs are still coming in by land, literally by the truckload from Mexico. So cities, states, and nonprofits will have to step up in order to maintain and grow treatment capacity. The poppy is likely to persist until we have a more fundamental shift in attitudes about opioid addiction as an illness, more attention to mental health and prevention. There's a great overlap between other mental health problems and substance abuse, so mental health services are really, really key. Prevention programs, screening to identify people who are beginning to have drug problems before they become addicted to opioids. And reductions in sources of despair, like chronic and underemployment. For those of you who are interested in learning more about system dynamics, hopefully you kindled a little bit of interest. There's a System Dynamics Society, which has a website with all kinds of resources, and the address is just systemdynamics.org, and that has a lot of useful resources. So thank you again to the library and to those of you who've come come here tonight and to those of you watching on Zoom. And I'm happy to take any questions. Steve.
Thanks, Gary, for putting such a comprehensive program out here. It's a little overwhelming on the receiving side to understand the magnitude of the problem in all the dimensions. Perhaps you might talk a little bit more about, from my perspective, what kinds of treatments are there? Are certain treatments more effective than others? And do you learn anything from treatments that tell you how to prevent people needing treatment in the first place?
Well, there are a couple of different kinds of treatment. I mean, one I didn't mention is drug-free, which, with some people who are highly motivated, is successful, or they're detoxified from active addiction, and then go on without any medical assistance, any other drugs at all. And then there are drugs, methadone, which up until recently had to be administered daily, which really sort of made holding a job or something like that a little difficult. And then buprenorphine, which patients basically can be prescribed. It takes care of the effects of being without opioids, the withdrawal symptoms, and those seem to be more effective. The medication-assisted treatment seems to be more effective in dealing with that. I imagine people who work in the rehab field a lot, gain something from understanding how people got involved to begin with. But again, I think prevention, as I said, really involves dealing with some of the underlying problems, often other mental health issues, that without adequate mental health services, you're going to keep, having problems.
A question on Zoom. This person was struck that deaths by alcohol and suicide seem to track somewhat and took a dive with the passage of prohibition. Is this a case where just say no actually worked?
Could you repeat the question?
So the question was that in the graph I showed you, where in deaths of despair, deaths by alcohol seem to go down during prohibition, and so was this an example of where just say no may have actually worked. Well, it wasn't just say no. I mean, the alcohol was a lot harder to come by, not impossible, but I think it was the prohibition itself was more than just saying don't drink. Yes.
You commented briefly in the very end there about the Oregon experiment. Did you build loops from anything?
I'm sorry?
Did you build your model out to show why that, didn't work? It sounds like that would have been the logical extension of the work that you have done.
It's actually something we're working on right now, trying to use our model, the one we've developed in New York State, to explain some of that. And I think part of it just had to do with when the police didn't have anything to arrest people for because possession was no longer illegal. They just kind of sat back, and so people using drugs were doing it out in public and getting the rest of the public really upset. Business owners would have people, sort of shooting up right in front of their stores and so on. And I think the other problem was that Oregon sort of treated legalization as a one-shot thing. It's, okay, we'll legalize and see what happens, but they really needed to, at the same time, in a coordinated manner, really expand treatment capacity so that you could take advantage of people not being in jail, but get them treatment and hopefully get them off the drugs. That makes sense?
Yeah, but, my kids use that all the time. It seems like if what you are trying to do is really get at first-time addicts, it's gotta be more than just the people who are doing it out on the street. Why didn't it slow down?
Well, there was no reason, just based on legalization alone, for things to slow down. This is a sort of an important lesson in terms of the needs for comprehensive, coordinated strategies. The police could have actually played a very valuable role because they were out on the street all the time, seeing what's going on, and instead of arresting people, sort of getting them to go into treatment if there was more treatment, but again, there wasn't that kind of coordinated strategy, so that there were just people out in the street using drugs, but it didn't really contribute to treatment at all. It was just again a one-shot idea. It basically a good thing. I mean, you shouldn't be arresting people for something that's essentially a medical problem. So legalization didn't mean that legalization was a bad idea, but just that it was an incomplete idea. You had to do it and several other things to really have a meaningful impact on the problem.
What about the European experience, which seems so totally different than ours? What are they doing right?
So the question was about the European experience, and Portugal is often pointed at as the one country that's really done it right. But again, it was done in a coordinated manner. They did provide treatment in addition to legalizing possession. So again, it's that coordinated strategy. I think other European countries have probably done it better as well. Oregon, I think, is now rethinking what how it should have done things. Mal?
Yeah, I have in my practice seen the results of people who have been involved with heroin. And I had clients who were in a Nazi concentration camp, and they decided when they got out they were going to make money the fastest way they could, and they went into the heroin business. The results were eventually they got caught, but they got credit for the time that they had did in the concentration camp. But the sad part is that I have met people who have been addicted, and I had one client who used to shoot between her toes.
That's
and,
common.
Your heart wrenched for these people.
Yeah.
But they were committing crimes, and they needed a lawyer to support their habit. It was a going around circle of addiction, crime, and going to jail or whatever. It's a tragedy, and I felt sorry for them. In the end, there was very little I could do for them to stop the situation.
Yeah. And those personal tragedies also have ripple effects through the rest of the community, both people being victims of crime and then the community going downhill. So we were talking about that sort of downward spiral that might occur, and whole neighborhoods really end up suffering. Yeah. Linda?
So this morning I opened the news, not the national news, local, and was really unhappy to read about what's happening in Davis Square, Somerville, which we frequent quite often. And things have gotten out of hand rather quickly. And here it's right here under our noses, literally. I don't know who was elected as mayor tonight or today, but I certainly hope that there will be more thought and care given to this, because people will leave, businesses will be threatened and close, and the ripple effect is horrific on personal and family and communal life. So maybe there's more fodder close at hand to deal with.
You know, well, so what complicates it is that drugs aren't an isolated problem. They're interwoven with a whole bunch of other problems. I think I mentioned earlier that I've also done some work in youth homelessness in Connecticut, and a lot of drug use involved in that, as well as sexual exploitation, things like that. But a lot of the kids you see hanging around Davis Square and other places like that, had been in foster care and then just sort of get dumped out onto the streets and fall prey to drugs and sex and all kinds of things. So these are really complex problems, and societies really have to invest a lot of resources to deal with them effectively. And unfortunately, we often organize our services in silos. So there's law enforcement, there's mental health, there's housing, and they often don't talk to each other. One of the nice things about the system dynamics work that I've done is that we tend to pull together kind of interdisciplinary teams of people from these different silos, and they actually talk to each other while they're helping us develop these models. It's really something to see.
I would think that you would have to work closely with the treatment centers. Is there a shortage, or isn't that one of the areas that would help the system?
Of course, not only do we need to coordinate well with them, but they also I think, as we were saying earlier, have the knowledge of understanding why people become addicted, what happens once they're addicted, and so they can really inform the work as well as being an important part of it. Steve?
One of the points on your curves is the availability of drugs. Okay. If we could do a significantly different job in terms of the availability of drugs, for OxyContin, I think we stopped the doctors from prescribing so much, and that seemed to have an effect. If we spent a lot of time and got the fentanyl coming up from Mexico, which is coming up by trucks, as everybody doesn't know because there's a whole bunch of politics involved. But if we really spend an effort and got that availability down, which is sort of cutting the supply off, do you think that would have a major effect in the problem?
Probably not, because you saw what happened. Heroin was coming in pretty large volumes from Mexico. There were whole villages. There's a really good book, I'm blanking on the name, that sort of has alternate chapters between a village in Mexico that sort of becomes a heroin producer, and a town in Ohio, I think, or Kentucky, where people are becoming addicted, and just going back and forth between those two. And so heroin was a big problem, but got totally displaced by fentanyl. And wherever you can set up a small chem lab, I've read lately that fentanyl is now being displaced by yet another new drug. So as long as the demand is there, you can affect supply temporarily, but then a new drug is going to come along, or a new source is going to come along, and you've really got to work the demand side as well as the supply side. What we found in our work in New York, that law enforcement had a really critical role to play. It wasn't just take the cops off the street and open the treatment centers. You really had to do both, as well as work with the kids in a credible way. You couldn't just say, don't, just say no. You really had to, sit down with them and really help them understand the consequences of drug use.
Something that may have been mentioned but not highlighted, the chemistry of the brain per se. It's not the drugs, it's the brain chemistry that the drugs feed and have effects on. So as a psychologist, about 50 years ago, I was also interested in why there wasn't more research and treatment of the way the brain functions. Some people are thrill seekers. some hide, some seek, and then they become addicted because it's like, Alice in Wonderland, feed me. So I would like to see more funding and research done on the neuro side as opposed to the criminal side.
Well, that's, I think, one of the sad things of what's happening, the funding at
Yeah.
NIH and National Institute on Drug Abuse, that there is clearly a need for that kind of research, and yet, some of those agencies are just being decimated. Courtney?
I have a simple question about the systems thinking and the loops. How do you weight each curve? Does that go into a computer model?
Yeah. So, often, there will be research studies that we can find that will say, peer pressure is, twice as important as, something else. And so we'll cull from the different research studies that have already been done, or we'll sit down with a knowledgeable group of people who run treatment programs and are working with a lot of addicts and saying, which do you think is more important, peer pressure or drug availability? And they'll say, well, it's really peer pressure. And so we'll give that a weight of 3 and the other weight of 1 or 2. So it's a somewhat organic process to kind of cull from different sources and use expert judgment where the studies don't exist. Yes.
I haven't heard you talk about, and I know this is an unsolved problem, more education in the schools as far as not necessarily heroin, but psychological effects of how the kids react to heroin.
Okay. So the question for those on Zoom was, what about education and in the schools doing something with kids to prevent that? And there, I think one thing we felt fairly strongly about was the education had to be credible. I remember in high school, in what was called hygiene class, even before high school, yeah. No,
Middle school. I know I was active in Lexington in the DEA program. Did you do that?
Yeah. No, I mean that's clearly important. Preventive education. But again, I think it has to be credible. The kids pick up a lot, just from their friends in terms of what's real and what's not real. Yeah.
And interfere with that credibility between the peers. And see how
Yeah.
we
Yeah.
can do that.
Yeah. It's a question back there.
Yeah, thank you for this, and you've offered a lot of information, and your graphs are wonderful. Number one prevention education campaign in the country that brought down youth rates over a short period of time and pretty dramatically was the Truth campaign, which was around nicotine, tobacco.
Huh.
And it did so for, it held those numbers low. I mean, it was like I don't remember off the top of my head what the percentage rate it was, but it was remarkable how that campaign impacted the youth culture. And that campaign was wrapped around the manipulation around tobacco companies.
Yeah.
You are the target market
Yeah.
because they want lifetime consumers of their product, and that worked. And that model sort of went like this when the tobacco companies got behind education, and then sort of they shifted the whole education around to the medical model about why it harms, and they took out the part about manipulation. That these people are trying to manipulate you.
Yeah.
And when you got a graph there about how America and the United States, their opioid rates are soaring,
Yeah.
and Europeans.
Yeah.
And I would love to see somebody research. I mean, I think that's intentional and deliberate. You want to destroy a superpower, you fill their communities with drugs,
Yeah.
and you have their people turn on each other.
That's right.
Yeah.
Communities turn on each
Yeah.
other.
Yeah.
So we're getting double whammy legalize, should we not legalize? We're fighting within our own communities.
Yeah.
And I think that's deliberate and intentional because there's a lot of world out there ready to take down the U.S. and this is
Yeah.
the way to do it.
Yeah.
So I just think that that is something that gets overlooked. Like we're all just, I mean, I don't want to be that naive anymore. I think people need to wake up. There's a real intent here. I also think that one of the things that has really worked over history with the decline of drugs in youth culture is perception of harm. So when people understand that a drug has a certain level of harm, they're less likely to, to try to take it. So there's those pieces, there's parental disapproval. I mean, it's so complex, right? But when you have stuff coming from the top, where they're pushing drugs into your communities and allowing, I mean, when you've got like, I just think there's something there.
Yeah.
And we miss the boat by not talking about that piece.
Yeah. Also, I think political ideology is a factor. I suspect those European countries where you saw the very low level of use had, drug regulation that really, looked at the facts and said, no, these are dangerous. And so there was a lot less of it in Europe. And the U.S., it's, the corporations, have sort of bought Congress, and so there was no regulation. The pharma companies were allowed to just sell opioids based on the flimsiest of evidence. Okay, well, I think we're...
Thank you so much.
Okay, well, thank you.